Bloom IVF is now 20 years old. And as you grow older, you mature and your experience also increases. And now we are really seeing a lot of patients with recurrent IVF failures, meaning more than 2-3 IVF ICSI failures coming to us for treatment. And we are doing a lot of extra things and getting these patients pregnant. I think the whole attack towards these patients is multifaceted. We have a pre-ART therapy where if the patient is obese, she is asked to reduce weight. If it's polycystic ovary, we do believe in giving metformin. If there are fibroids, we believe in doing a myomectomy, either laparoscopically or hysteroscopically, or sometimes we even use medications to reduce these fibroids if there's multiple small fibroids. Then another factor that we really give importance to is hydrosalpinx. In hydrosalpinx, the tube is enlarged and filled with dirty fluid. So this tube is a defunct tube. It is of no use to the patient. So what we do is we go and de-link it from the uterus, because this fluid actually comes into the uterus and prevents the baby from growing there. So hydrosalpinges are to be de-linked. Endometriosis needs to be treated. If there is endometriosis, which is primary endometriosis, no surgery done, we'll definitely do surgery. But if repeated surgery has already been done, the ovarian reserve of this patient is done, and we assess what is her status. And if there are endometriomas, then we use GnRH analogs. Now these injections for a long period, 3 to 6 months, have really improved our pregnancy rates. Patients of adenomyosis also benefit by giving GnRH analogs. So these are some of the pre-ART therapies, and most importantly, a hysteroscopy. A hysteroscopy in all these patients really helps us improve their pregnancy results. We've seen a lot of things which cannot be picked up by three-dimensional ultrasound, like a polypoidal endometrium, or maybe the damage to the endometrium which causes release of very pro-pregnancy factors. So in this way, hysteroscopy helps us get pregnancies in recurrent IVF failures. This is the pre-ART part. The stimulation protocols are important. So we use different protocols depending on the requirement. We have the long protocol, we have the antagonist protocol, we have the Tokyo protocol. So each protocol is tailor-made to the patient. Then after the stimulation is the laboratory. And I think the lab is the heart of it. It's really the most important part, and technologically the advances, the new technologies which Bloom IVF has introduced over the last 20 years is something that today gives us an authority to be able to treat these recurrent IVF failures. The assisted laser hatching, which we introduced in 1998. After that, we introduced the blastocyst culture, which is growing the baby outside the body for 5 years. After that came the treatment of spindle view, where we could actually identify the spindle in the egg, and so as not to damage the chromosomes. Then came the IMSI, where the male factor was taken care of. The sperm was enlarged and we were able to bypass the male factor. Other technologies like vitrification, giving storing embryos, getting fantastic retrieval rates, and giving a better cumulative pregnancy rates in these patients. Because sometimes the ovarian induction which we use may not be favorable, create a favorable endometrium or an environment for the baby to transplant. So the vitrification has helped us, overcome this particular problem, especially in PCOS patients. Then the technology of in vitro maturation, especially in Delhi where I practice, see a lot of patients, and some of them have benefited from in vitro maturation. Then of course the egg donation and surrogacy technologies which have become available and have really improved pregnancy rates in recurrent IVF failure patients. Then we use, after the laboratory, then the new incubators, the MINC incubators, the air handling units in all the laboratories, and a well-trained staff. We have a good embryology backup staff, a good staff, the nursing staff, and the doctors. I think, that is the most important part another aspect which gives us better results in these patients. After which is the luteal support. We have altered the luteal support in many ways depending, it's patient tailored, and that also I believe has helped us in getting better pregnancy rates. So all this is a multifaceted approach which we have for recurrent pregnancy losses, and that has helped us give pregnancies in this very, very difficult group of patients.